At the physician pre-conference this morning, we talked a lot about value and quality as a subcategory of that, and there was a lot of conversation around getting rid of unwanted variation, and that's our next topic to open up here after the break. And we have three great speakers, all physicians from different programs. Dr. Peter Duffy is an interventional cardiologist, and he's with First Care. Dr. Tom Schleeter with St. Vincent Health in Indianapolis, and then Dr. Craig Strauss with the Minneapolis Heart Institute. So, gentlemen, talk to us about unwanted variation.
Good morning, or good afternoon, actually. I'm Craig Strauss. I'm a cardiologist with the Minneapolis Heart Institute. And I'm going to take the next couple minutes to talk with you about a topic that you see there, leveraging data to reduce variation in cardiovascular care. My hope is that with that topic, you're not going to feel the EKG tracing that you see in the bottom corner of the slide, because it does sound a little boring. But my hope is that at the end of this talk, you will realize and be as enthused and excited about the opportunity to leverage data and reduce variation as I am. So as I said, I work for the Minneapolis Heart Institute, which is part of Allina Health. Minneapolis Heart Institute is about an 80-physician cardiology and cardiovascular surgery practice. We are a high-volume practice, seeing about 60,000 clinic visits, 48,000 echoes per year. Allina Health is an integrated delivery system in the Twin Cities in Minnesota with 65 health clinics, 12 hospitals, retail pharmacies, and ambulatory care. When we think about variation in healthcare, it's important to think about the types of variation. There are two types of variation in healthcare. The first is necessary variation, and that's deviation from standard care that's based on individual patient characteristics, allergies, patient preference, things like that. The second type of variation in care is unnecessary variation. That's the variation which does not result in benefit to the patient and often is associated with increased costs. There have been a lot of studies around variation in practice patterns and variation in care in healthcare. Some of it coming from the Dartmouth Atlas, which is the graph you see there. The green shows areas of lower cost, and the blue shows areas of higher cost. And when they look at unnecessary variation, the biggest driver of unnecessary variation is variation in physician practice patterns. When you look at physician practice patterns in detail, higher cost regions have not been associated with improved quality or outcomes. That background led us at the Minneapolis Heart Institute to develop a center called the Center for Healthcare Delivery Innovation to target a lot of the challenges that we're all facing and that have been talked about here today. Pressures to transition to value, the pressures around payment reform, new players coming into the market to disrupt the way we provide care. And our MHI Healthcare Delivery Innovation Center developed 4 foundational pillars. The first is population health management. So we engaged in things like looking at, among the patients that we care for, are they on appropriate statin medications based on guideline recommendations? We focused significantly on reducing clinical variation, and we've done over 100 projects to reduce and standardize clinical cardiovascular care across the Allina Health system. The third pillar is to test new processes of care and payment models. We've engaged with different payers, with industry, bundled payments, and things many of you have also begun to participate in to figure out how we can provide high-value care at lower cost. And the fourth pillar is to leverage cutting-edge technology. We all get excited when there's a new technology, the opportunity to replace an aortic valve with a catheter as opposed to a sternotomy. But we have to figure out who are the right patients to get these new technologies, and how do we track and optimize the outcomes of those patients. The backbone of our HDI center is our enterprise data warehouse. And Allina's enterprise data warehouse is composed of over 75 sources of data, of which our medical record system is one of those sources. So we're able to actively link clinical data, financial data, including cost accounting data, some payer data, patient satisfaction data, national benchmark data, registry data like STS and NCDR. And we can bring those together, condition-specific dashboards like these snapshots that you see here, to identify areas of opportunity to improve outcomes and reduce variation in care. So we analyze these opportunities, we identify the opportunities. As I said, we've worked on over 100 over the past several years. We develop metrics and protocols to optimize the care, eliminate waste, and reduce variation. And we closely track the outcomes, both quality improvement and financial. And when we look back on the impact that we've had on cardiovascular care across the Allina Health System, the quality improvement outcomes are significant. In the past 3 years, we saved 3,330 units of blood. We avoided 3,200 hospital days. We reduced heart failure readmissions by 5%. We eliminated 142,000 unnecessary lab tests, avoided over 1,000 CV-ICU admissions, and optimized the care for high-risk patients undergoing PCI in just under 1,000 patients. And as Michael Porter has identified, quality improvement is the most powerful driver of cost containment. And so in addition to those quality improvement outcomes, we've seen a significant impact in cumulative savings. In 2018, we'll celebrate $50 million in savings to the health system related to those initiatives. And so with that, I'm going to pause and turn it over to Dr. Schleeter.
Thank you, Craig. What a nice presentation. As Joel said, my name is Tom Schleeter, and I have the privilege of being a cardiologist at St. Vincent Medical Group in Indianapolis. St. Vincent Medical Group, like Craig's practice, like Peter's practice, is a large practice. We were formerly known as the Care Group, and in 2010, we became employed physicians with Ascension. We now are a multi-specialty group with roughly 1,500 physicians and 200 advanced care providers, 90 full-time cardiologists, 22 or so APPs that are specific to cardiology. We have roughly 45 hospitals that we've furnished care to in the state of Indiana, 22 of which are aligned, are part of the St. Vincent network. The remainder are not. And as we talk about reducing variation and eliminating that issue with us, that is a challenge in both types of regions, both with the system and outside the system. And roughly 45 clinics throughout the state. We have a long history of trying to reduce variation and standardizing what we do. Before we formed the Care Group in the 1990s, the two big groups in Indianapolis that formed the basis of that formed the Indiana Heart Institute, which was the first vehicle in the state of Indiana to really work with payers and negotiate contracts, and that was a very successful venture. Rich Fogel, who has been up on this stage before, who is now the Chief Clinical Officer for Ascension, Indiana, started EP device standardization, really cutting down the amount of devices we're using in the EP lab, trying to focus on a few and really negotiate favorable rates, and saved upwards of tens of millions of dollars doing that. Dr. Ed Fry led that effort in our PCI lab, standardizing wires, balloons, and stents, and realizing tremendous cost savings with that. When we became part of Ascension in 2010, we've been part of their vertical integration efforts ongoing. There's always challenges with that in any industry, even outside of healthcare, when you see the issues that go on with vertical integration. But things like supply chain and some management skills certainly seem to benefit and certainly allow us to contain costs a little bit more effectively. We talk about eliminating variation and trying to standardize care. We really try and do that through our robust PI and QI committees. We have 8 of them. They're run through the cardiovascular service line, and they range from, you can see them up there, open heart surgery, ACS, heart failure, and so forth. We meet monthly, report quarterly to the CVSL, and certainly we establish all our local benchmarks for each institution, each ministry within our hospital system. Try and have that for a statewide approach for standardization, and certainly trying to become the national benchmark for ascension as we move forward from a cardiovascular space. Where we've seen some successes in reducing variation. 4 years ago, if I stood up here and talked about radial access for cath, I would have some of my doctors were doing that 100%, some of my doctors were doing that 0. I'm pleased to report that over the last 4 years, we've gone to almost a 90% radial artery access rate in our institution, like many of you out there. That's facilitated a same-day PCI discharge. Patient satisfaction scores go up. That's a nice thing to always see. Always interesting when you see the changes in this that you don't see coming. Certainly affects the bottom line a little bit when you're discharging patients sooner, but always a good thing though. And certainly it can affect your registry scores as well because you make your denominator a little less. We've really honed in on our post-procedural order set adoption, trying to standardize. We're talking about EP devices or the such, standardizing the use of antibiotics, standardizing the use of imaging. Some doctors were ordering different types, some doctors weren't ordering any, and really have standardized the way to treat that patient. In heart failure, and my clinical background is certainly in heart failure, one of the things we tried to stress in heart failure was we saw, even though we have quite a busy VAD transplant program in the state of Indiana, we have 2 other competitors who have fallen on hard times when we talk about advanced heart failure. We are quite busy and robust. We have a busy VAD service. We're going to do about 80 to 90 VADs this year and 50 to 60 transplants, which will both be high numbers for us. Even in that realm, we saw that our heart failure, just our general heart failure scores weren't where we thought they should be. Our rate of readmissions was too high, our length of stay was too high, our mortality was too high. And certainly, like a lot of you out there, as cardiologists, when we were trying to focus more on the quaternary type of things in the cath lab, procedural-wise, we were trying to get our patients, especially in our large tertiary hospital for run-of-the-mill heart failure, to be cared for by general internal medicine. And what we found is, by analyzing that data, that our colleagues in general internal medicine weren't as aggressive enough with their diuretics. They certainly weren't using them as often or as strong as the majority of cardiologists were. That's where we really dove in and developed a heart failure diuretic protocol order set that could be initiated for any patient with a diagnosis of heart failure. And so far, we've had that instituted for the last 15 months. Over the last 15 months, we've seen decreases in our length of stay, readmissions, and mortality. Certainly not saying that's all due to the diuretic order set, far from it. But shining a spotlight on this process has certainly led to better outcomes. Our discharge process was, quite frankly, in disarray. We tackled heart failure immediately. The idea of having a standardized way to discharge these patients, both with educational resources and prompt follow-up. We initiated a phone number for people to call and really tried to wipe out that variation in care. Right now, people, once discharged, if they're in the city of Indianapolis, they come back to our transition care clinic within 72 hours and heart failure clinic within a week. And then as we standardized the way we were looking at each readmission. Each readmission was being looked at by perhaps a different committee or different set of doctors. We take a much more rigorous look at this and having a standardized way to approach the failure of care that led to readmissions. We certainly have a lot of work to do. We're hamstrung by our EHR. We don't have the ability to have something like Epic or Cerner. Certainly what we have right now, both from the in and outpatient setting, is a little bit lacking. We're working on adopting inpatient order sets to really drive out variation of clinical care. I think if patients come into the hospital, there should be a standardized way to get them in your hospital and hopefully have a standardized way to take care of that disease process for that patient. Still working on our outpatient issues as well. We'd certainly like to build in, like many of you have in your EHR, a standardized protocol for disease-specific things for our patients. Still lacking that right now. I'm still working on that. Then our EP lab in particular, we're struggling. We have plenty of patients. We still have a 3-month backlog to try and get people in for ablations. That's difficult for our patients' stomach, and it's difficult for our financial colleagues' stomach as well. So we're trying to standardize the way we utilize our EP lab, standardize the way we use our staff in our rooms. Certainly hope that will lead to improvements as we move on. I have the pleasure of introducing Dr. Duffy to finish us up.
Thank you so much. Appreciate that. And those were 2 fantastic talks and really give examples of what goes on in those institutions. I wanted to just follow that up by what I hope are just some practical tips on how we can take this into each of our own institutions to really create value for all of our partners there. So let's say we've decided now we're going to go ahead and change physician practice patterns, which is really, as Craig alluded to, one of the major issues and drivers of variation, unexplained variation in care. How do we go about doing that? Well, the first thing I think we should look at is the goals that we have in mind there. What do we want to influence and how do we want to change that? And these are just what are called SMART goals, SMART standing for specific, measurable, actionable, relevant, and timely. So specific simply means we need to focus on something that we really can come down on and see how, if we change that particular part of a physician's practice behavior, it's going to influence and give us better outcomes. Measurable, certainly, because physicians are going to want to know, how do we get this information back? Is this something really that we're measuring accurately? Is it actionable? Can the physician actually do something about this if we want to change that for that particular process? Is it relevant? Is this something that payers are looking at? Is this something that patients are looking at? How is this important to your system to change this type of behavior? And last, is it timely? And timely comes really in two forms. Are we getting the information back to the practitioners in a way that they can actually use it? So if we're looking at data from 5 quarters ago, that's not really going to help us change behavior for the coming quarter. And timely also based on payers. So for example, door-to-balloon time has been a moving target with respect to whether we're getting dinged for not meeting door-to-balloon times or not. So do you want to focus on that and put resources into that if that's not a real major source of payment issue for you there? So one way of looking at this, and this is an example from the NCDR database, is by going back and looking on an individual physician basis, and each one of the colors of the bars represents an individual physician. This is feedback that we get from NCDR, and it tells us whether that physician's care for a particular patient has been appropriate, may be appropriate, or is rarely appropriate. Now, rarely appropriate, of course, doesn't mean it should never be done. So we break down rarely appropriate into rarely category 1 and rarely category 2. Rarely category 1 is there's documentation there to support the need to actually do that procedure for that particular patient, and an unbiased observer, someone else in the group who didn't know whose case he was reviewing, agreed that that was an appropriate thing to do. Rarely 2 means that we don't agree. Either there was not documentation there or the documentation wasn't sufficient to support doing something like that. So this is the type of information that we, in our institution, want to collect and be able to give back in a timely fashion to physicians to be able to meet what we consider quality guidelines for NCDR. Another way of looking at this is bubble graphs. I don't know how many are familiar with these bubble graphs, but we find these extremely useful as well. So this is trying to change physician behavior with respect to length of stay and cost issues. So on the x-axis there, you can see length of stay, and on the y-axis, the cost per physician. Each of these bubbles represents a particular physician, and the size of the bubble represents the volume for that physician. So you don't want to be the physician who's in the top right there, who's got the longest length of stay and the highest cost for a particular procedure or process. You want to be down toward the bottom of the left. And we can break this down by PCI, we can break it down by left heart cath, and we can break it down by right and left heart cath. We also do the same thing for EP, and we do the same thing for vascular, but I didn't show those slides there. So once you have that information, how do you get that back to the physician? How do you then try to change physician behavior? Well, the first thing we do is share blinded data. So the physician will get that information back and be told you're either what color you are in the column, but you won't be told who all the other people are, just who you are relevant to your peers there. Then the next step after that is sharing that in a group setting, just physicians in the room, but physicians are told who the other physicians are. They're in either those bubbles or those bar graphs there. And that would be sharing unblinded data. And that does tend to create a lot of peer pressure because nobody really wants to be at the top on the right there in the bubble graphs or have the most rarely 2 inappropriates that are done in the PCI lab. So that we do see changes behavior. With the advent of physician integration into healthcare systems, we also see contracts can be very useful because there can be specific goals set in those contracts to be able to meet the measures that you want to improve quality and improve physician performance in a way that influences quality patient outcomes. And incentives for physicians who may not be contracted but may be in a PSA or some other way that you may not be able to monetarily reward them for meeting the criteria that you've set up, but there may be some other way to be able to do that. The nuclear weapon, frankly, unfortunately, is credentialing, and that really is the hospital's responsibility. The responsibility of a board is for quality and for finances, and if you've got somebody who is doing cases that are clearly inappropriate, and that's been documented objectively and even looked at by outside observers, credentialing may be the only issue the only method really of of getting changes in physicians' behavior or not having your institution any longer responsible for physician behavior. But to me, again, that's a nuclear option that we really never have had to use. I want to finish by just talking about concepts, because I think the concept of how we go about looking at this is critically important, because we tend to get down and dig into the data on things, but we want to really understand what we're really trying to do. And in economics, we call value quality over cost. But when I look at that, that doesn't really help me take care of a patient, because I can't figure out exactly how we integrate that into daily practice. But what I think does help me is what's called the real value formula, or the real value equation. And it has 4 components to it. Appropriateness is number 1, and appropriateness drives value. And appropriateness really should be looking at, when we're doing whatever it is we're doing, is the patient going to be feeling better because of this? Is the patient going to live longer because of this? Or are we going to prevent something bad from happening to that patient because of this? And I think if we can't answer yes to one of those 3 questions, then we really need to be thinking about how appropriate is it for us to be proceeding in the direction that we're now recommending. The second is clinically defined outcomes, and that really goes back to the practitioner. What does the practitioner expect to happen under this particular circumstance? What's the best possible outcome that they're going to expect from doing this procedure or proceeding in this direction when you take care of that patient? Third is patient-expected outcomes. Patient-expected outcomes are important as well, because if you're not meeting their needs there, their expectations of what it is this procedure, or this process, or this treatment plan is going to deliver for them, there's a disconnect there. And we really want to integrate patients' thought processes and their desires into how we really take care of them. And last is resource utilization. And resource utilization really comes down to not just direct costs, because in some cases we can find those out and sometimes we can't, and indirect costs, but it's opportunity cost as well. If we're doing things that take us away from something that we could be doing differently or better, then that's an opportunity cost for us as physicians. If our cath lab staff is tied up doing that, doing an unnecessary procedure instead of quality work, that's an opportunity cost as well. And then lastly, there's what I would call the ripple effect, which means the daughter or someone else who had to take time off from work to take her dad or mom to the hospital that day and now loses a day of work for something that didn't necessarily need to be done. So I think that when we look at this in totality, if we keep that concept in mind there of everything being driven by appropriateness, and then integrating clinically defined outcomes, patient-expected outcomes, and resource utilization into any plan that we devise, then I think that really is going to set us apart as a healthcare institution from our peers. Thank you. We made these talks short so that there was a lot of time for discussion and questions afterwards, so we didn't want to give 45 minutes worth of talks there. So we certainly welcome questions.
I'll kick off with a question for the audience who hasn't started down this path. Can you kind of describe what you would do as first steps to get started on reducing unwanted variation?
Yeah, I would say the first step is to understand what data you have and the accuracy of the data that you have. As an industry in healthcare, we are overwhelmed by data, and much of it isn't really useful. And you really have to sort out what are the subset of data fields that are most important that you want to track and utilize, and make sure that those are accurate when you capture them. And that forms a foundation for how you can develop your metrics to track things going forward as you make changes in processes of care.
Anybody else want to take a stab at that one?
Yeah, I would say that one of the major things really is to create the sense of urgency that something has to be done, because if it's just another process that we're going to put in place now and there's no real sense of why this has to be done and why it's going to harm the institution if it's not done, and why it's going to really help the institution if it is, then buy-in tends to be difficult. Physicians, you know, I think we in this group are pretty unique, and when I go back and talk to many of my partners, peers, and colleagues, this is not something that's on the top of their minds all the time. It's, you go figure that out. They have to have a burning platform in order to really respond, and I think we need to create that sense of urgency.
There's a lot of different options for improving patient care, and I think everybody in their own institution can really recognize their issues. I think the data is vastly important, don't get me wrong. In fact, it's very important. We struggle with getting that data, but a lot of times we're able to identify, is it a procedural-based problem? Is something wrong with patient care? And if you start at that route, I think you can really do some favorable changes to your patients.
At any time, audience, feel free to raise your hand and we'll pull you into the conversation. What do you do with the physician who just refuses to kind of go along with the will of the group on changing to get rid of unwanted variation? What are some strategies for groups that might be struggling with that?
I think Peter outlined it very well. I think we're all competitive. We didn't get here by accident, and I think the competition to provide better care certainly goes a long way. We certainly aren't looking to embarrass our colleagues, far from it, but if you're not doing the same way others are doing things, and remember we're talking about evidence-based things, we're not talking about seat-of-the-pants type of things, really pull that physician in, have a clear conversation, then we post the data. I think Peter alluded to that very, very well, and I think that goes a long way to changing behavior, at least in our practice.
Unfortunately, you have to find pressure points in some cases there. You know, what does this person want? What does this person not want? And they have nothing to do with money. It may have to do with parking spaces. But there's things that you can really influence there and say this isn't going to work that way. The medical executive committee is another good example of where you can go before you go to credentialing, which I mentioned previously. If somebody has to go before the medical executive committee on a monthly basis to explain why their bubble is in the top right and everybody else is in the bottom left there, behavior will change in our experience.
Any other questions from the audience?
I have a question for you. So I was thinking that Atul Gawande is probably developing a strategy right now as we speak. And this morning we heard from Jerry Blackwell that it takes 17 years for a new protocol, new drug, et cetera, to be fully implemented. Have you heard from any payers in your market that are looking at this, that are starting to raise some questions?
Heard from payers around the Atul Gawande work or around any initiatives?
Any initiatives with regard to unwarranted variation?
Yeah, I think the payers in our market are interested in reducing clinical variation in care. The data is somewhat limited when you look just at claims-based data, and the infrastructure that our payers have in our market is relatively archaic in terms of their ability to rapidly transition to new models of payment and tracking some of this data. So I think it's been slower for them, but we have pursued a number of value-based initiatives in things both within and outside of cardiology.
Do you generally find that administration is supportive of your efforts, and not just from a yes, go do it, but from that full circle follow-up when you need to go to med exec and when you need some pushing? Have you found that support?
I certainly have at our institution, but it's interesting when you talk about someone who may be an overutilizer of PCI or something like that, who's outside of the plot curve that we looked at earlier. They're supportive until they start thinking about the bottom line a little bit. And I'm not saying they're not supportive further, but there always is a little bit of pause when you tell, hey, this is better for everybody, but we're just going to cut out some procedures. Going to come out billing's going to go down. They're okay with that, but you can see it gives them some pause, and that's part of their job, is to overcome that.
Yeah, and we're still in a pay-for-volume. We're not in a pay-for-value world at all yet. And even when you look at MACRA and moving to MIPS, MIPS really doesn't cap volume at all. It may cap what you get paid per procedure, but it doesn't cap the number of procedures that you can do. So I think until we see the evolution into the ACO models and more bundled payments and a patient-based population payment for X number of people, I think that it is going to be a very difficult situation there, as Tom alluded to.
Yeah, volume still rules in most of our houses. Any questions from the audience for our panel? Okay, thank you guys. We really appreciate it.
Thank you.
Thank you.
Well done.